Thank you, guys. Thank you. Come so that we can start today's presentation. Today's presentation is titled Laboratory Diagnosis of Hemophilia, and will be able to explore key tests, factor assays, and diagnostic pathways used in identifying and managing hemophilia in clinical practice. And our presenter today is going to be Mr. Benjamin Ochieng, who is a qualified medical laboratory officer. Currently, he works with the Metropolis Kisumu branch as the lab manager, and he's also currently is also lecturing at KMTC Lake Victoria. He's also a TOT in hemophilia, and that is why today we are privileged to have him so that he can train us on matters hemophilia. I hope, Benjamin, you are active and ready to start the presentation. Are you able to hear me, Benjamin? Hello, Benjamin, are you able to hear me? As we sort out the presenters, maybe the the voice, we are encouraging all to come so that we start.
I think you can speak now.
Yeah, Benjamin, are you able to hear me now? Thank you. We're starting soon, so we're encouraging all to come so that we proceed. As we wait for the presenter to activate his voice, thank you, guys. Lab diagnosis of hemophilia is our topic today, and we're going to explore the key tests, factors assay, and diagnostic pathways used in identifying and managing hemophilia in clinical practice. In the different laboratories, we need to have this training, and therefore we've started it off today. Hello, Benjamin, are you able to hear me now? Hello, Benjamin, are you able to hear me now?
Yes, hello.
Yes, I
Yes,
can hear
yes,
you.
Benjamin.
Thank you so much. Sorry for that hitch. And
Yeah,
now,
thank you, Benjamin. Are you able to hear us now?
yeah, loud and clear, and I'm able to see the slides.
Yeah, thank you. Thank you, our participants. We're sorry for the delay, but I think we can start now. So, Benjamin, we invite you to start your presentation. Welcome.
Thank you so much. As you have been told, the participant, I am Benjamin Uchimupio. I overheard that I work at Metropolis, not at Metropolis. I work with KMTC Kisumu and the director of Gamud Star Labs Kisumu. Thank you. Next slide, please. Now, today our presentation is about hemophilia, and hemophilia is really a challenge in Kenya. I expect at the end of this presentation, all the participants who work in the lab are able to perform screening tests for hemophilia and other bleeding disorders, perform the confirmatory test for hemophilia and other bleeding disorders, implement a quality assurance program in all aspects of diagnosis. Next. Now, in the outline, as written there, we have the background of hemophilia in Kenya, overview of hemostasis, specimen management, screening test, and confirmatory test. Next. What is hemophilia? Hemophilia is an inherited bleeding disorder that is always a sex-linked in fashion. It is due to defective factor 8 and factor 9 genes, leading to deficiencies in factor 8 that is related to hemophilia A, factor 9 related to hemophilia B, which is also called Christmas disease, leads to deficiency of clotting proteins, that is coagulation factors, presenting also as abnormal bleeding tendency. Next slide, please. Then why hemophilia? Background in Kenya, it is under the Kenyan Haemophilia Association, which was established in Nairobi in 1979 and recognized as a national member organization by the W or the World Federation of Haemophilia in 1992 as the official Kenyan patient organization. The Kenya Haemophilia Association presents the rights of all patients living with hemophilia and allied bleeding disorders in Kenya. It was established by Edward Kasisili, Professor Walter Mwanda, and Prof. Grace Kitonyi. Next slide. Now, in Kenya, this hemophilia is treated in specific hospitals and they are given as cohorts. When you are in coast, I know most of us are here works in these facilities. In coastal region, we have Hola County Referral Hospital, Moi County Referral Hospital, that is Voi, Coastal Teaching, General Teaching and Referral Hospital, Kilifi County Referral Hospital, Kwale, that is Zambweni County Referral Hospital, Mandera County Referral Hospital. Then when you come to central cohort, we have Kenyatta National Hospital, Meru Teaching and Referral Hospital, Murang'a County Hospital, Laikipia, Narok, Garissa, we have Marsabit and Kitui. Then when you are coming from Western, you need to know these facilities. We have Moi Teaching and Referral Hospital, Nakuru Referral and Teaching Hospital, Kakamega, Busia, Kisii, Bungoma, JOTRH, which is Jaramogi Oginga Odinga, Kapenguria, Lodwar, IRC, Kakuma, and Kakuma Sub-County Hospital. Next. Now, just a minute. This is the map of these facilities you have talked about and how they're well distributed. So whenever you are or wherever you are in Kenya and you are in need of such services, you can visit them. Next slide. Now, currently, this is the total number of patients suffering with this disorder that is called hemophilia. In hemophilia A is 987. Hemophilia B is 193. Volwin-Brand factor disorder is 33. Other platelet disorder 5, leading to a total of 1,218. The expected number is ideally in Kenya 5,700. The current identification rate is at 21, and others 79 yet to be identified. And that is why, therefore, we are holding this webinar so that the lab technologists can help us to identify these patients who present in the hospital with a bleeding disorder by diagnosing them well and giving appropriate data for identification. Next slide. Now, this is how it is distributed. This estimated frequency of hemophilia is around 1 in 10,000 live births. And the number of people worldwide living with hemophilia is 400,000. Hemophilia A is more prevalent, that is 80 to 85 of the total hemophilia population. It presents in 1 to 5,000 live male births. Then we have hemophilia B, 1 into 30,000 male births. Volwin-Brand factor disease is in 1% of the general population, affecting or affects both male and female population equally. Next slide. A Kenya Haemophilia Association receives treatment products, and this is what you need to know, lab officers and lab technologists there, to advise your clinicians accordingly, and doctors and nurses, that the Kenya Haemophilia Association receives treatment product as a donation from the World Federation of Haemophilia through a 5-year agreement between the Ministry of Health and World Federation of Kenya. Treatment can be received at any of the 25 established hemophilia treatment centers in Kenya. Next slide. Then why hemophilia? There are those who always present themselves at our facility with such kind of swellings. And you will see clinicians, doctors probing them, trying to find out whether there are some a pus inside to suck. And with hemophilia, when you do that, you are causing trauma, and these clients continue bleeding inside. And they can bleed to a point of death if you don't really identify the cause at the hospital. And that is why we give you these pictures to appreciate. Like in this case, we have hemorrhagosis, that is joint bleeding. Look at how that child, the joint has swollen. It starts like aura, then tingling, then tightness, followed by increasing pain, progressive loss of range of motions, then increasing swelling and warmth. So one of the condition, hemorrhagosis. The next slide. We have soft tissue bleeding. They will also present with soft tissue bleeding, with severe bleeding is associated with shock compartment syndromes. And how to evaluate this is automatically by HB, vital, and a distal neurovascular involvements. Another slide. Now, this is to make us appreciate the need why we have to identify these patients at the lab with accurate results that can inform their treatment. Next slide. Other complications, they will have a CNS and intracranial bleeding, throat and neck resulting from local trauma, severe cough, or local pathology. Those who just cough or someone has infection in the throat, then also local traumas can lead them to bleed in the neck and throat. Then gastrointestinal bleeding presenting as hematemesis, hematosia, and melano. Then we also have oral hemorrhage, and many other complications. You just try to eat something, you see the gums bleeding. Someone will just treat it as normal, not knowing it is caused by hemophilia. Continue, next slide. Then for us to understand this as lab personnel, we have to understand briefly hemostasis, which most of us are aware of. We know it involves three major stages: vasoconstriction, platelet plug. We have the coagulation, then coagulation cascade, and finally, we have the fibrinolytic effect. So hemostasis is a physiological process that ensures that blood is maintained in its liquid form within our blood vessel. A dynamic process that involves a balance between procoagulation and anticoagulation. In balanced cases, either hemorrhage or thrombosis can occur. Platelets, vascular endothelium, coagulation factors, natural anticoagulants, and fibrinolytic system. A system of check and balance involving the blood vessel system, platelets, and a series of enzymatic reactions of specific plasma proteins. That is what hemostasis is all about. The next slide. I've talked of major components. You heard me saying about vasoconstriction. When you have a cut or you have a trauma or you have a bruise, the first thing is for the vessels to constrict, then a platelet activation to form platelet plug. Then now the coagulation factors that are formed in our livers will also come to help here. Then finally, what has been formed now needs to be removed, that clotting, so to allow the blood to flow normally the way it used to. And I know most of us are aware of this. Next slide. But our main concern is the secondary hemostasis, where we talk about coagulation cascade, when we leave the platelets plug aside. Why? Because this is where the factors are majorly utilized. So in a coagulation cascade, it is a sequential activation of coagulation factors that circulate in their inactive forms. Next slide. Next slide. Good. The next slide is just to give you a picture of intrinsic and extrinsic pathway. When we introduced hemophilia, we said that hemophilia A is due to deficiency in factor 8. Hemophilia B is due to deficiency in factor 9. And this majorly requires or involves the intrinsic pathway. So from our background of hematology, we know the intrinsic and extrinsic pathway, and you're able to see there. The next slide, please. Now, what is the role of blood? Laboratory evaluation of hemostasis in general. And this is what you need to know as a medical laboratory technologist. Laboratory diagnosis is the key in unlocking hemophilia. Doctors will find it hard to diagnose and understand the cause of bleeding in new cases without the assistance and the availability of hemostatic tests that needs to be done. Next slide. It involves 4 major steps. Which ones are these? Then a complete history that must be taken from the patient, and as lab, we know in our lab request form, there is a brief history that is given. in the request form. Then physical examination by a clinician or our doctors or nurses. Then as lab, we do complete blood count. The question is, why do we do this? We want to check the HB. We want to see which cells are interfered with, which ones are high, which ones are low. In the case of hemophilia, what do we need to see? Then peripheral blood film, why do? We check on the platelets majorly. Here we want to see the aggregation, we want to see exactly you are dwelling on platelets. Then screening of coagulation tests. Then specialize or the special test to define the precise nature of the defect. Next slide. Important to note, for laboratory tests to have any significance, the sample taken must be suitable for the parameters being measured. The test system must be properly regulated, that is SOP, and must be adequately quality controlled processes, or both internal and external QCs must be run so that you know that the result you're giving is a result that can advise the doctor to give the patient a proper medication. Next slide. In laboratory, without proper sample management, then ideally we are not giving what is going to help our patients. So the first thing you have to do, good quality result relies ideally on the sample quality. The anticoagulation of choice for coagulation test is ideally 3.2% sodium citrate, and EDTA is used if a full screening is required in cases of hemostatic test, and specifically in this context, we are talking about hemophilia. The ratio is always 1:9. I always see people just get sample for the sake. As a lab personnel, check whether in that sodium citrate tube, has the blood filled the margin to allow the ratio of 1:9, which is required. Then there should be very minimal venous stasis. That is, tourniquet application must be or should be under 1 minute. Next slide. Then collection of sample from indwelling catheter should be avoided. Mixing is done by gentle inversion. Samples should be collected as near the testing laboratory as possible to avoid that long time transportation that can lead to giving some errors. Then test analysis should be done within 1 hour after sample collection. Then sample transportation. Sample collected far from the testing laboratory should be processed as follows. Note this: spin the sample at 3000 RPM for 10 minutes. Transfer the PPP or platelet poor plasma to prostate poor plasma to a plastic screw cap tube. Then the last thing you need to do, freeze at -30 or -80 degrees centigrade until the transportation time. Next slide, please. D, what you really need to do again is to place in dry ice or liquid nitrogen during transportation. That is for long distances, or on ice, but should be for at least 1 to 2 hours. Do not store the plasma at 2 to 8 degrees centigrade. That is a cold activation of factor 7. Another slide, or the next slide. Now, screening test. As a lab officer, what are you supposed to do the first time the client comes and you want to screen? Screening test is a preliminary procedure to detect the most characteristic signs of a disorder that may require further configuration. We will start, or you need to start with prothrombin time test. What is its main purpose? Always it is normal in this case of hemophilia. If it is abnormal, then you are required to check your QC. The patient's liver function test needs to be done. Why? Because we know most of these coagulation factors are synthesized in the liver. Then you will do activated partial prothrombin test. That is always abnormal result in these cases of hemophilia. Then thrombin time or fibrinogen analysis is always normal in hemophilia. Then you are required to do CBC, which is low, red blood cell count, HB, mean corpuscular volume if bleeding has been ongoing for a while. Then quantitative platelet disorders may be noted from a CBC. That is why we do CBC. Hello? Kindly continue projecting. Hello?
Yes, Mr. Benjamin, you can continue as we sort out the. You can continue as we sort out the projection.
Okay, thank you. A team, as we continue learning this, you are seeing we have just mentioned about screening test. And this is the valuable point that you have to know when the client comes and you are screening for hemophilia. What are you supposed to do? If you do PT, it is always normal. If it is abnormal, check your QC or assess the liver function test to check on the enzymes or if there is a defect in the liver. Again, we have talked about APTT, which is always abnormal in cases of hemophilia. Thrombin time, fibrinogen assays, we have said they are always normal. After we are in slide 27, just go up a bit, one slide. Good, that's where we are. Then we have also said when you check on CBC, the red cells count will be low, HB, and mean corpuscular volume. It will also be low if bleeding has gone for long. Then quantitative platelet disorders may be noted from a CBC. And now you see why we have to do CBC in this case. Next slide. And now, thrombin time. Why do it here? It is a time taken by citrated plasma to clot in presence of tissue, of factor, and calcium. It always assesses the extrinsic pathway. That is, tissue factor will activate the extrinsic pathway by activating factor 7 onwards. The normal range, as we always know, is 11 to 16 seconds. Then PT abnormal in cases like deficiency of fibrinogen, thrombin, factor 5, factor 7, factor 10, there is bleeding, liver disease can lead to such, then therapeutic, that is monitorable anticoagulant therapy for warfarin can lead to that, acquired inhibitors to coagulation factor can lead that, because you might have developed antibodies that inhibits the coagulation factors to function well. The next slide, next slide, please. Good. And this is INR. INR, we know how to do. When you're doing INR, you do patients, a plasma that you required. Then we have the normal.
Mr. Benjamin.
Yes.
Participants are requesting that you slow down. You are a bit fast.
Okay, thank you.
Yes.
That is now well noted. When you are doing the INR, what do you require? You required a patient's prothrombin samples of prothrombin time. Then we have the normal reference range. Then we have ISI, that is International Sensitivity Index, for us to get the optimum for us to get the test. But this INS is always between 1.3 to 1.5. Normally, we say you can find it by yourself by doing a panel of tests, then find the mean, then you use it against the normal range that is given. And mostly I see, like where I've worked, you will be doing like 10. Then after 10, you calculate to get the range that you're working with. So international normalized ratio, which is the INR described from prothrombin time, used to standardize warfarin therapy around the world. And how to calculate this, it takes into account the sensitivity of the reagent, to the effect of the warfarin on extrinsic pathway. Only for warfarin monitoring, that is when you really need to do it, for warfarin monitoring. Then note, PT and INR is normal in cases of hemophilia. This is very important to us because some people will report they see abnormal and presumptively thinks that the client has hemophilia. If you do this test, from our up slides that we have presented or we have gone through, we said the PT is always normal in cases of hemophilia. So take note of that. Next slide, please. This is the reaction. This is just a simple way to give you what PT assesses. It assesses the extrinsic pathway, not intrinsic. But hemophilia is majorly in intrinsic, factor 8 and factor 9. Next slide. Now, activated partial thromboplastin time. What is this principle? It is time taken by a citrated plasma to clot in presence of negatively charged contacts, activators, that is silica, kaolin, aganic acid. We also have phospholipids, a partial thromboplastin, and calcium, or in bracket, a calcium chloride solutions. If thrombin time is normal, an abnormal APTT usually indicates deficiency of factor 8 and factor 9, and occasionally would lead to factor 11 and 12. And we know factor 11 is always associated with hemophilia C. I hope we remember our hematology as we are just about refreshing our knowledge. Next slide, please. Then how do we do it? It's a demonstration of intrinsic pathway and common pathway, that is from factor 10 downwards. Normal range for APTT is 25 to 35 seconds. APTT is abnormal in such cases of hemophilia, and we are also given a range of where you will find it abnormal. Inherited deficiency like fibrinogen, thrombin, factor 5, factor 10, factor 9, factor 8, factor 11, and factor 12. In bleeding cases or disorders, others, we will see the APTT also raised. If there is a liver disease, therefore, we will find synthesis of these coagulation factors being low, hence leading to a longer time or APTT time. Then therapeutic, that is in cases of heparin, we can also find abnormal APTT. Acquired inhibitory or inhibitor factors can lead to such, and we will see in the next slide how that affects. And then what you have to note is APTT is abnormal in hemophilia because our main discussion is hemophilia. Next slide. Now, this is just a presentation, just to bring you a pictorial presentation of the pathway that is always assessed by APTT. Next slide. What are the confirmatory tests in the lab? Now you have found the factors APTT to be high. To confirm this, we have what we call a mixed studies or factor assays. What do you do here? Just to explain this, a mixed studies, you have found this person has hemophilia. You don't know whether it is hemophilia A or hemophilia B. You will get the platelets, the plasma that has factor 8. And be very keen here. You add that factor in the patient's blood and see whether it has corrected the deficiency or the factor that is low. If it was factor 8 and you see it has been corrected, then you will know that this client was suffering from hemophilia A because I added factor 8 and now it has corrected the problem. If you add factor 8 and it has not been corrected, automatically you know it is not hemophilia A. So you will add factor 9 to see whether it will correct the problem. If it corrects, then that is factor 9 deficiency. So hemophilia B. And that is how that makes studies are done. Some people call it correction or factor assays, how they're done. Then in case of inhibitory is where that your body or your immune system has developed antibodies that prevent the actions of these factors like factor 8, factor 9. This is analyzed through a technique that is called Bethesda analysis or Bethesda assay analysis for quantification of the inhibitors. Then we have platelets aggregation test, platelet receptor studies. Then for the Vol-Willebrand factors, because you know without Vol-Willebrand it also affects factor 8. Then you will do aristostatin cofactor assays, Vol-Willebrand factor 8 binding assay, Vol-Willebrand collagen binding assays. Next slide, please. Now, this is how mixing study or the mixing, the correction and substitution is done. An abnormal APTT is followed by mixing studies or mixing patient plasma and normal pooled plasma in a ratio of 1:1, and an APTT done to check if it's a factor deficiency or an inhibitory leading to the abnormal results. The principle here is when the patient plasma is mixed with normal plasma or normal pooled plasma, if APTT does not get normalized, or if there is a less than 50% correction, it indicates the presence of an inhibitor. However, if it does, then correction, we conclude it's a factor deficiency. Similar tests performed with specific factor deficient plasma samples will indicate factor deficiency if there is no correction with that specific deficient. Next slide, please. Then a correction with factor 8 deficiency means there factor 9 deficiency. A correction with factor 9 deficiency means there is factor 8 deficiency. The note, what you have to note, a correction with both factor 8 and factor 9, then therefore you need to check your QC. What is the clinical history of the patient and multi-factor deficiency? Why is this point important? So many people classify patients as being hemophilic, yet they are not. So you have to check your QCs. Then don't be in a hurry to make a diagnosis. Request for a fresh sample if you find there is a problem. Next slide, please. This is just now a pictorial. We have deficiency of factor 8 and factor 9. APTT is abnormal in both. Normal plasma added, there is a correction. A deficient factor 8, if it is factor 8, no correction. Factor 9 automatically will see there was a correction. If therefore you add a deficient plasma of factor 9, there will not be correction in factor 9, but a correction in factor 8. It is a simple thing. I have a sample or a plasma which is deficient of factor 8. If I add it to hemophilia A, I will not see a change. So it means there is no correction. That is what it says in mix or correction tests. I believe we understand, but if you don't understand, we will answer you at the question time. Next slide. It is still the same thing, the presentation. An example of APTT mixing studies. You will see the normal pooled plasma as given a change to 32. Patient sample is 96. If you add these two, there is a correction, but slightly. You are able to see that at this stage now, when you mix patient
Benjamin? Benjamin, are you able to hear me? Sorry, we seem to have lost our presenter. Let's hope he's sorting out the network challenge that he has. Then he'll be joining back in a few minutes. He'll just be joining in a few minutes, so let's give him some time. Meanwhile, we'll wish to remind our participants that we've got the link to join LMSK that we've shared in this presentation. We've also shared the link to one of our WhatsApp groups so that anyone who has not joined can as well join that particular WhatsApp group. And to members who will wish to ask questions, you can type your question at the Q&A so that we'll be able to answer them at the end of this presentation. Again, just a reminder that you take note of the details that we've been urging you to check when it comes to registration of these webinars under LMSK so that it gives us an easy task when uploading
Hello,
your results. Yes, Benjamin, you're back.
I'm back. Sorry for that power
Yeah, thank you.
hit.
Thank you. Go ahead. Go ahead.
So we got affected when I was explaining how to do this mixed study. And I was saying you are able to see here in the normal pooled plasma, we are able to see that when we run APTT, the second is 32. When we check for the patient, it is 96. Now, when you add the patient and N PP or the normal pooled plasma, it is 31. A correction that has been done is only 1 second. So it means that pooled also had deficiency of the factors. Then when you add patient factor 8, deficient plus patient, it is 92. It means that that sample is highly deficient and there is no correction. We are starting to think about factors. Then when you add this patient's plasma to that of the deficient of factor 9, we see a correction from 92 to 37. We are starting to say that there is a problem specifically with factor 8, but not factor 9. So this is just an example on how to check on deficiency of factor 8 and factor 9. Next slide. Then this is a complete assay test. A complete assay test run. When you check on factor 8, you will always find APTT high with normal PT. When you do factor 9, APTT will be high with normal PT. Same all through to factor 11, in factor 12, factor 7, factor 2. In factor 2, factor 5 and factor 10, you will realize PT is high and APTT is also high. In factor 7, normal APTT with a high PT. In factor 12, high APTT with no bleeding. In fibrinogen or factor 1, prolonged PT and APTT if low. What does that say? In A, as I have said, factor 8, that is hemophilia A, factor 9, hemophilia V, factor 11, hemophilia C. In the presence of high APTT with no bleeding, that was not clinically significant. When you check on the factor 7, normal APTT with high PT, rare conditions, they don't normally occur. Then high PT with also raised APTT, then we have liver disease and vitamin K deficiency. Then in cases of prolonged PT and APTT if low, then hypofibrinonemia and DIC. Next slide. Then this is just a presentation on how to do the dilution when you are performing these assays. You can perform by diluting until you get to the right figure by doing the correction study. So you see, added in 1, there was slight lower or reduction, added to 2, slight reduction, added to 3, until the correction is done in the system. Thank you. Next slide. Then factor assay, one-stage assay principle. APTT, based factors activity assays, measures the clotting time of dilution of the test plasma compared to serial dilution of a reference standards. That is normal. Plasma is ordered to quantify the level of factor activity in the test plasma. And then both test plasma and reference plasma are diluted and mixed with a factor deficient plasma. Then APTT clotting time data of the reference standards are plotted on a log of factor activity, linear clotting time, graphs, and interpreted in order to allow the calculation of factor. And this is majorly in the correction assay. Next slide. And then factor assays deficiency, mild hemophilia A and hemophilia B. You will always see if you do a correction, it corrects between 5 to 50% of factor 8 and factor 9. The moderate hemophilia, factor A, factor B, the correction will be 1 to 5 of factor 8 and factor 9. Then in severe cases of hemophilia, when you try to identify, you will realize that as you try to correct, the client has low factor 8. Are you getting that? Below 1. So those who will present with mild, they will be having about 55 to 50. The moderate 1 to 5. Then very severe cases, they will automatically present with less than 1. So when you do a correction study, you can find that data. Next slide. Then inhibitory factors or inhibitors. Inhibitors are when your system have developed antibodies against the clotting factors, against the factor 8 and factor 9, despite correction. However much you are trying to give the client the right factor, there is still no correction of this hemophilia. As a lab tech or as a clinician, you put your head together and identify whether the cause is due to inhibitors. Therefore, how do you need to analyze this? So inhibitors are generally suspected in patients having prolonged bleeding episodes who do not respond well to the conventional factors replacement therapy. So screening for inhibitors are also recommended before surgical procedures. Like you have a mother who needs to be done CS, you have any other surgery that takes you in and you know this person is hemophilic, first assess because the patient might bleed to death if this is not factored in. So that's why we are told screening for hemophilia, for the inhibitors are very important to help in this. Then patient earlier diagnosed with inhibitors need to be periodically monitored to ensure efficacy of treatment. Next slide. The procedure of inhibitor assays will still continues. An inhibitor screen in hemophilia entails the mixing of patient's plasma with pooled normal plasma in equal portions and run APTT on this mix. If still abnormal, no correction done, then the mixture is read at 1 to 2 hours incubation of factor 8 or 15 or factor 9. Note the time. For factor 8, it's 1 to 2. For factor 9, it is 15. If the APTT reading of the incubated mix much longer than the immediate mix, it indicates the presence of inhibitors, which is subsequently considered by or confirmed, not considered, confirmed by Bethesda assays. Next slide. Now, this is how it is done, and this is how Bethesda assay looks like. The positive inhibitor screen leads to an inhibitor assay, Bethesda assay, to identify if it is a high titer or a low titer inhibitor. Get that? The Bethesda helps you to know whether it's a high titer or a low titer. High titer is measured is above 5 Bethesda units per milliliters. Low titer is less than 5 Bethesda units per milliliters. Next slide. Then Bethesda assays, as it continues, the mixture is incubated for a specific time, usually 2 hours, as said for factor 8, and 10 minutes for factor 9. And it is incubated at 37 degrees Celsius. After incubation, the residual factor 8 activity is measured to determine the amount of inhibitor present. 1 Bethesda unit is defined as the amount of inhibitor that reduces the factor 8 activity by 50% in the mixture. Next slide. The Bethesda test, also known as the Bethesda assay, is a laboratory test used to detect and quantify inhibitors, that is antibodies, against factor 8 in individuals with hemophilia A or other bleeding disorders. The Bethesda assay involves mixing a patient plasma sample with normal pooled plasma that is containing known amount of factor 8 and a buffer to stabilize factor 8 activity. Next slide. Then the purpose, ideally, the Bethesda assay determine whether a patient, the hemophilia A patient, has antibodies to factor 8. Next slide. An interpretation is as said. I've said this, but just to repeat, a positive result indicates that the patient has antibodies against factor 8, which can interfere with treatment. The strength of the factor measured in Bethesda unit determines how much the factor 8 is neutralized. Inhibitor levels are expressed in BU, and that is Bethesda units, where 1 Bethesda unit is defined as the amount of inhibitor that neutralize 50% of factor 8 activity in normal plasma. Next slide. Then other methods that can be employed here in analyzing or assessing the factor or hemophilia A inhibitor. It is in inhibitor in hemophilia A patient may also be determined using high sensitive assays such as Nijmegen ultra-sensitive Bethesda assay or ELISA that we always employ in our facilities. Next. And this is the end. After I know this was an intense presentation with a lot of hurry to capture with the time, which is 1 hour. But I thank God I've just done in 59 minutes. So it's question time.
Yeah, thank you, Benjamin, for that good presentation. And so we also want to check on this question so that we can also help our members understand further on matters hemophilia. And we want to look at our first question from Julius Gedinji Mutore. And he's asking, is there any explanation as to why hemophilia A is more prevalent than hemophilia B? Back to you, Benjamin.
Yeah, that is a very good question. From our initial slide, I think around slide 4-5, if we go back, we say it is ideally sex-linked. Then hemophilia A is always linked to von Willebrand. And in the process of lack of von Willebrand, and again with the liver complications, like when you have liver problem, the factor 8 is always not produced or it is low in the system. By such, hence, it is very common as compared to others. You know, we know these factors, they are factors that are produced in the liver, and there are those that are produced within our blood vessels. So that, from my understanding, I believe that is why factor 8 deficiency, or hemophilia A, is very common as compared to others. So if your liver is affected, and we know what affects our livers, just to expound on this, when you take alcohols that leads to liver disorders, or you have hepatitis, the condition that affects the liver, automatically your factor 8 will either not be produced enough, and that will lead to such kind of cases of hemophilia, which I believe all of us understand from our background of hematology. I believe I've answered him. If not clear, then I can as well do more references.
Thank you. Let's look at our next question, and it goes from Moses Onyango. Why is hemophilia more common in male than in females, whereas females are mainly carriers? Yeah, this is a question that has been repeated with different participants asking the same. Kindly, Benjamin.
Yeah, we have talked about being a sex link, and we know that with the XY, when a father who is hemophilic donates that X with the X of a female, which is normal in that case, would automatically lead to carrier. One X being affected while the other X is not affected. But in case where you inherit for a male, you only inherit X and Y. So automatically you will be totally affected because you have one X that has affected you. But again, in the recent study of hemophilia, this contention of being a carrier has been an issue. And I believe those who have been trained just equally like me as TOTs of hemophilia, this is a question that we have always asked, but they said, do not classify them as carrier. Once identified as hemophilic, treat. Arthur, that is
Thank
how the
you.
current guideline says. Once
Thank you.
diagnosed with hemophilia, treat. Yes.
Yeah, thank you. Another question from Benedict Wachala, and it goes, now, why is hemophilia A more rampant in men than women? And then, why is it still at 21% identified patients? And yet, this is an association that is almost 50 years old. 50 years old. I mean, what is hindering patients to be tested? And yet, we have many hospitals for the diagnosis and treatment.
Thank you.
I think he's referring to the Society for Hemophilia, but you can expand on that. Yeah.
Yeah, just because we also asked the same question and this was the response, I believe most of us are here who also were in these kind of trainings. They said that when a patient presents in the hospital with anemia, you just diagnose anemia and you continue looking on other diseases, overlooking this hemophilia. By the time you are realizing that this patient is hemophilic, either deformed, bedridden, or some of them have died. So misdiagnosis has led to this, and that's why this presentation has been very pivotal to identify. So the guideline says, through the Kenya Haemophilia Association, that so many people are outside there but not being identified as hemophilic, hence the low data.
Thank you.
Back to you. Yeah.
Yes, Gideon Rotich is asking, geometric mean, in bracket, geomean, is used in coagulation for what purpose? How is it calculated? That's the question.
That one, I don't have robust knowledge on it. If I give, I'll be misleading.
Thank you. Question from Anonymous. Differentiate between intrinsic and extrinsic factors.
Thank you. From our presentation, it was so clear because tissue factors initiate extrinsic, and we know factors that are found there, like factor 7, that is commonly in that pathway for extrinsic. Intrinsic, we talked about kallikrein that initiates this, and the factors we know that are here is factor 12, factor 11, factor 9, and factor 8 in that order. So that is the main difference here. And when we are talking about the test, we talked about the PT assessing the extrinsic and common, while APTT assesses the intrinsic and the common pathway.
Thank you.
Yes.
Matthew Simiyu. Matthew Simiyu is asking, APTT is abnormal in hemophilia. Kindly clarify abnormal with which deviation. Does it give high level or low level results? Back to you.
Thank you. Thank you so much. If you saw the presentation, if you joined early enough, you realize that we gauge the severe hemophilic, moderate hemophilic, and mild hemophilic based on the APTT. So you will find even APTT of 34, 36, 37. That one, a deviation of 1 to 5, 1 to, we talk about 5 to 50%. 5 to 50, that is mild. If there is a deviation where the factors is between 1 to 5, then that is moderate. Then a severe case is someone when you analyze, the factor is below 1. How do we find this, or how do we detect this in the lab? After doing the APTT, which is a screening test, then you go and do other assays like mixing or correction or substitution to gauge what amount of factor 8 is the patient having, so that you know this is a severe, this is moderate, or this is mild. That is how I respond to that. And it is in our presentation, which I'll also share.
Thank you. Emmanuel Mbevi is saying, a very informative presentation. And he adds and says, and asks, do we have an automatic machine which can diagnose factors deficiencies? And what is the costing range? Back to you.
That one I cannot really give a valid response because this one would be presented well the biomeds and the equipment companies that are available. Mine is to give you the knowledge and what you need to do as a lab tech, like the screening test, the confirmatory tests that are available, and how to identify an hemophilic patient who presents at your facility. But that is a very good question. How I wish we had the equipment companies presenting on this. Thank you, Dava.
Thank you. Yes, Lawrence Kosgei is asking, can hemophilia disease be found in sickle cell affected patients?
Yeah. Thank you for that. I think that's why the Haemophilia Association, the Kenya Haemophilia Association, is interlinked with the sickle cell, because a sickle cell is complete different disorder, and hemophilia is complete different disorder. They can affect a patient both. Hence, a patient might have hemophilia at the same time be a sickler. So it is possible. Thank you. Back to you.
Yeah, another question from Kenneth Achieng, and I think you will be able to understand it well. How will you be able to know if a factor needs incubation or immediate interpretation of the results while doing a mixed study?
Yeah. When you're is she asking the time, or is she asking how to interpret the result? If you have to get
He's
clarity.
asking if the factor needs incubation or immediate interpretation
No,
when you are doing a mixed
that is
study.
when you're doing a mixed study, there is an incubation period where we said when you are doing it for factor 8, it is 1 to 2 hours. If it is factor 9, it is 10 to 15 minutes.
Yeah, thank you.
Yes.
Another question from Albert Chen. Sample testing in regards to hemostasis disorder diagnosis, is it within 1 hour or for 4 hours after collection? Kindly
Come again.
clarify.
Come again.
Sample testing, sample testing in regard to hemostasis disorder diagnosis.
Mhm.
So the question is it within 1 hour or 4 hours after collection that we do
Yeah,
the sample
it is.
testing?
If you can do it immediately, if you are able to have the equipment or the facility for testing, you'll do it immediately. But if you have to transport, from our presentation you have seen, we have said within 2 to 4 hours. And again, when you are transporting for long, you have been told how to preserve, where we have said you use the nitrogen or cold ice.
Thank you.
Yes.
Lawrence Kosgei is asking, does nose bleeding indicate a deficiency of a certain factor? And if it does, what factor is that?
Epistaxis, which is the nose bleeding, can also be due to hemophilia, because any trauma, like kids who like putting their fingers in the nose, or when you are sneezing, you cause us trauma. And then if you have such kind of bleeding disorders, you continue bleeding, any little trauma you're bleeding, any touch, any bruise, anything, then start querying hemophilia, start querying. So you proceed to the hospital for screening in relation to hemophilia. So that is a very good question. As at the same time, not being just medics, we are also parents and we are also interacting with people. Or we might be the people with the issues, nose bleeding. If you feel anything, if you sneeze, your nose bleeding, then visit the hospital for a screening. Start with APTT. Then, if you're found to be high, proceed with the specific hemophilia assays.
Thank you. Another question related to that from Anonymous. Can you classify nose bleeding as hemophilia case?
Not generally until it is assessed. Yes, you cannot split because of hemophilia, but until it is assessed and confirmed that it is due to hemophilia, then factor correction needs to be given to you. Yes.
Thank you. Ahmed Hassan is asking, what is normal pooled plasma?
A normal, nice. No, it's, people or individuals with normal factors, factor 8 and factor 9, you'll take their blood, get the plasma. Then now that when you bring plasma of 2, 3, 4 people, meaning you have pooled them. So that is the normal pooled plasma. Normal in the aspect of factors, factor 8 and factor 9. Then pooling means you bring so many blood or individual samples. Then you mix, and the sample is a plasma. So normal pooled plasma.
Thank you.
Back to
Lawi Mwangome is asking, what are the automated techniques in detection of hemophilia?
Thank you. We have talked about ELISA technique, which I know the manufacturing industries and equipment industries might have made such kind of equipment. Like just the way we have equipment that we use to analyze APTT, or coming from the older manual ways, I believe the equipments are available, but until we get someone to explain further from the manufacturing industry, we can be informed. But for now, personally, I'm not in that field. Thank you.
Yes, thank you. Joseph Zakayo, what is the probability of inheritance of this red cell abnormality?
What is what ability? Come again.
What is the probability of inheritance of this red cell abnormality?
That one I cannot ideally link. But if a carrier, you have a normal male spouse and a female carrier, the probability is automatically that you might have all your males that are affected. Are you getting that? You get all your male affected. But if it was only a male and a normal mother, then expect ladies to be carriers, your daughters to be carriers. But in the case where you have both male and female are hemophilic, then we are expecting a true hemophilia case, even to ladies.
Okay.
Back to you.
Another question from Fred Mose. Is hemophilia life-threatening?
Very true. After I saw a clip that almost made me shed tears, that a young kid in Mandera had been known to be handicapped, just walking with the palm of his hands and the legs are folding, and just walking, using his hands to scroll. Only for the one person, a Mzungu from abroad, just walking and just says, let us screen this child for hemophilia. When they screened that child for hemophilia, the child was identified to be hemophilia A. The kid was taken to KNH, and I believe those pictorials are there. That kid walked again and went to school. This is a child who has not been going to school, and people think he handicapped someone who is just, in fact, some considered a curse, kumbe ni hemophilics. So hemophilia is threatening because it's not identified easily, and at the same time, it makes people to be handicapped. Because if your joint is bleeding, that joint will never move. And anytime you try to move, trauma is caused and you continue bleeding. Muscles equally, throat ukijaribu kukohoa, if you try coughing, trauma, you bleed in the throat and almost everywhere. So it's a threatening condition.
Wow, I get you. Okay, another question from Nelly Chebet Butaki. Is D-dimer a significant test in hemostatic disorders?
D-dimer is a significant hemostatic disorders, but in case of hemophilia specifically, it is not that significant, according to this presentation. Thank you.
Yeah, there's a question here from Baraza Johnston. Are both hemophilia A and B treated with the injection of vitamin K?
No, not really. You will correct vitamin K and you might not correct the deficiency of the factors. So that is why there are, when it comes to medication, there are specific factor replacement that are available. And again, the most common one that is always being done is transfusion of the plasma or fresh frozen plasma or cryoprecipitates, depending on what the doctors prescribed. And again, just last month, we saw the factors that had been donated to the Kenya Haemophilia Association that they are giving. If we have anybody here who comes from Kakamega referral, I believe you know that the factors are there and they are getting them. Anyone from Bungoma, JOTRH, to be more precise, and KNH, and I believe hemophilia centers that I've mentioned, they have factors, but not just with vitamin K. In fact, the proper medication is factor replacement. Thank you.
Okay, another question from Mopa Pamela. After spinning, do we separate the plasma to another sodium citrate tube? If yes, will the anticoagulant in empty tube not affect the test?
It will affect. That's why you really need. We have the cryovials and tubes, plain tubes where you can really transfer the plasma. The moment you mix it with the sodium citrate tube, automatically you are raising the concentration where we talked of the ratio of 1 to 9 is already interfered with. So the report you will be giving is not a true picture of what the client has. So if that is the practice that we have there, then let us avoid it. Thank you.
Thank you. Emmanuel Kesa is asking, given the relationship between the liver disease and hemophilia, which factors are produced in the liver Which LFT's parameters are mostly affected with hemophilia? So those two questions.
Hemophilia does not affect the liver as per se, but if liver is affected, it leads to hemophilia cases because factor 8 shall be interfered with, and all the factors that he has alluded or asked that come from the liver. So it's not, hemophilia does not lead to the liver being affected, but liver affected leads to the cases of hemophilia because it produces factors like such factor 8. And many other factors that I believe most of us can do reference to.
Okay, thank you. Another question from Kenneth Acheng. How do you ensure the quality control measures are considered while doing a mixed study?
Now, that is a very good question. If you checked on our presentation, we were talking for a normal pooled plasma. First, ensure that the patient sample is put in the right tube. The right amount is also put in the tube so that the ratio of the anticoagulant and the blood is equal. Then from there, you can get, I believe, and I know there are commercially prepared normal controls that will help you to know that the mixed study that I've carried is a correct one. So you will automatically have a known factor 8 sample, a known factor 9 sample with a known pooled sample. Then you do that mixed study, or you get a sample which has factor 8 deficiency and factor 9 deficiency and do a correction or a mix test. Once you have a known samples, then you are good to go. That is how you do always QCs at your facility. A known case, either deficient of factor 8 or having factor 8. Thank you.
Okay. Another question from Frederick Odiwar. And the question goes, if, for instance, the mother who is to undergo CS is hemophilic and the condition is only detected on the very time of the procedure, considering time as a factor, what is the quickest response to this condition of the mother?
Thank you. Hemophilia is handled as a comprehensive multidisciplinary sector. It means it involves lab, it involves nurse, it involves orthopedic, it involves a physiotherapist, it involves all cadres because if someone is affected, even in the joint is needed there. So in the case of a surgery, the first thing you have to do is to make sure that the factor is available. So that if this client goes there, you have to correct the hemophilia state alongside carrying the surgery. So lab must provide the fresh frozen plasma for replacement as the surgery continues. The lab must also provide the cryoprecipitate in that case as the procedure continues. So they go concurrently. You are avoiding the excessive bleeding. At the same time, you are saving a life by carrying on the surgery or the CS if that is the matter. Back to you.
Yeah, another question from Janet Juma. Can a woman with hemophilia disorder give birth?
Yeah, they give birth. That one, they give birth.
Yes, thank you. Another question from Martin Njuguna. How does liver disease is associated with hemophilia diagnosis?
This one it's kind of like a repetition because we have talked about affection of the factor 8. So it's a repeated question.
Okay.
Because most of the coagulation factors are produced in the liver. Once liver is damaged in a way, it alters the functions of the liver, even for the production of the factors, hence leading to hemophilia case.
Okay. A question from Boniface Tor. At what age is hemophilia most common?
The age is not described. If you are hemophilic, you are hemophilic because it is a sex link. So even as early as you are born, you are born with it. But again, there is a discussion of could there be some environmental factors that would have led to genetical disorders when you have come of age that can make someone hemophilic. Like there was a case where someone is realized to be hemophilic at age 50, someone who was just normal. So that is now some thesis being developed, research to be done, but know that most people or almost all are born hemophilic because it is sex linked. It is inherited. Thank you.
And Faith Okech is giving some explanation here, but you can as well weigh in your thoughts. And she's saying gender chromosome mutation affects likelihood of having hemophilia. Male XY, one mutated X is disease high, and female XX, one mutated X is carrier low, unless both X's mutated or special case. You can weigh in your response on that.
Yeah, she's just repeated what I said, but I say currently with the Kenyan guideline, once confirmed hemophilia, whether carrier or not, because when you are testing, you are doing what we call phenotypic testing. When you now go genotypically where you want to identify which gene is affected, then you go how we explain. Our explanation is correct. But what do we do daily in our facilities? It is phenotypical. I've screened you, you are hemophilia, I found you have factor 8 deficiency, initiate correction. That is how it goes. I concur with her explanation genotypically. Thank you.
Thank you, Mr. Benjamin, for this very educative presentation that you've given us today. That I know many of us have refreshed because I believe so many facilities have not been actively practicing the diagnosis of hemophilia. But from this presentation, many of us will be able to rejuvenate and embark on this practice. As we adjourn, Mr. Benjamin, we'll request you to give us your parting shot because our time is high. We should be adjourning at 4:30. It's 2 minutes to 4:30. However, we cannot adjourn before you give us your parting shot. So we will allow you once again to give us your closing remarks, and then I'll give the way forward. Welcome, Mr. Benjamin.
Thank you. I thank everyone for joining this. And as you leave this webinar, start seeing any patient who comes with joint swelling, any patient who comes with muscle swelling and change of color of the muscles, anyone who comes with nose bleeding, anyone at phlebotomy whom you prick and you expect the bleeding to stop but still continues, query hemophilia. Initiate that even if the doctor did not request, inform the doctor, inform the nurse so that they can start screening for hemophilia. Let us bring all these people to picture so that we help. The drugs are so expensive, but we thank God the Kenya Association, Hemophilia Association is getting them as donation so that they can get them for free. Thank you.
Yeah, thank you so much, Mr. Benjamin, and to our participants. We also thank you for taking your time to join this webinar and learn. We invite you once again to our very next webinar that will take place on Wednesday. And so we also urge you to register with the right details so that you are able to receive your CPDs accordingly. We will be uploading our CPDs in the next 24 hours, the way we have been doing. And so we urge you to again register for our next webinar. Otherwise, we thank you a lot. And as we adjourn today, my name is Arthur Imari, the Secretary General for Lab Medicine Society of Kenya, and I wish you a good evening. Meet you next time. Thank you.
Thank you.